All right. Hey, everybody. Thank you so much for joining us again. We're excited to continue this conversation about the SMILE procedure. We're going to quickly just jump into an intraoperative complication case that we had in our practice. If you can just advance the slide here. This is just, a routine case starting off. And so it's really important that when we start the SMILE procedure, the first pass, the posterior cut, is very important. There cannot be any disruption. That is the refractive cut. So we can start the video and we'll kind of walk through it. And so it's just the regular case. You want to make sure you dock. It's really important as the procedure is going on. You really have to be in tune with your patient. I usually keep one hand on the forehead just to assess breathing, movement, just making sure everything is going smooth, assessing whether they're nervous, and verbal anesthesia is very important. And here it's just going very smooth and routine. And as it's going through, perfect. Posterior cut was excellent, but then you could start to see a little bit of movement, and I can sense the patient's getting a little nervous. And here you can start to see the eyes moving and shifting, and now we have a completely decentered anterior pass. And the patient's eye is definitely moving, and you can see here movement upon release of suction. And so it takes a moment to realize what you should do, and the most important thing is you should never rush if you don't feel comfortable. If we left this eye completely alone, it would return back to exactly what it was, and we could proceed with PRK and other modality to treat the refractive error or just do nothing. But in this case, because the posterior cut was perfect, we go ahead and proceed with the dissection even though it's a decentered anterior pass. And you can see the patient's just nervous, moving their eye, not making it any easier on me. But we do a little bit of a fixation technique, which allows us to first open up that anterior pass. And here we have to be extra cautious because things aren't the way they normally are. And then here we're just making sure we can get through to the posterior plane. We open it up, and then I go back and I dissect that anterior plane just to make sure everything looks normal there. And so far, everything seems to be okay, but I just want to make sure that when I take that lenticule out, I can have a guarantee to see that that lenticular piece comes out as a full circle the way we want to see it. And so the dissection is actually relatively easy. Um, and as we prepare for that lenticule to come out, I'm just making sure going around every single area just to see if there's any areas of abnormal adhesions. We could definitely make sure they're out. And so here I'm just going in and I use a forceps to grab that lenticular piece and make sure that it comes out. And when I put it out, this is the most important part. We need to make sure that that lenticule is whole. There's no tears or no remnants that remain. It's a little bit tough to see, but it actually was a perfect lenticule. And so in this particular case, even though there was movement, even though there was a shift, and we can go to the next slide. Uh, this patient ended up doing, we can go to the next slide, uh, completely perfectly normal. And this is the contralateral eye. Uh, in this case, this one was routine. You can see it's a more of an elliptical pattern at the start. This is a astigmatic correction. And here you can see this one stays completely centered. At this point, we're really talking to the patient, calming them down. Look at that perfect centration from the anterior and posterior cut. This one was very routine. And this is just a reminder as just to see the difference between the first and second case. Much easier and, less of a worry. But again, the key thing is making sure that that posterior plane is there's no movement or shifting. If there is, you must abort the case. You cannot proceed if there's any kind of suction loss or movement with the posterior plane. Once you get the posterior pass, you can, if you get suction loss, you can redock and redo the anterior pass a second time. So that's really, really nice to have that. And here, Second eye, contralateral eye, very straightforward and easy. But we always check and make sure that that lenticule looks perfect. And in this case, it does. Pay attention there. You see at the entry of the wound, there is a little bit of soft epithelium. It's good to see that because this will segue into our next case. So that's one thing we have to watch out for in Smile. However, this case ended up going perfect. Patient did great in both eyes. There was no refractive or visual effect, even though there was a decentration. We can go to the next slide. So just intraoperatively, the most important is the posterior plane dissection. Okay, just if it's performed, it's okay to proceed if you feel comfortable. If there's suction loss or movement on that posterior plane, just abort. And so, if it does happen in the posterior plane, you can convert to LASIK right then and create a flap, or you can pause and come back another day and either perform LASIK or PRK based on your comfort level. And the next case we're going to talk about, I'm going to let Dr. Tabanfar and Dr. Tseng take over. It involves more of the post-operative complications.
Be happy to. All right, so we have one of the issues that we do see from time to time with SMILE is the postoperative epithelial ingrowth. I'm showing you a case of a routine case of a 37-year-old female. Her preoperative exam was very routine, minus 4.5 of diopters in the right eye, minus 4.25 on the left eye, both eyes correctable to 20/20. And very, very smooth procedure. I don't have the video, but her vision 1 day post-op was 20/20 right eye, 20/20 left eye. And then we saw her for 2 months post-op visit, and her right eye had decreased to 20/40 and 20/20. So I have the topography for her. This is her 2 months post-op visit. The right eye, as you can see, there's an area that the cornea is elevated. The topography shows that it's irregular. And as you can see, also in the Myers, there's distortion. And that explains why her vision is 20/40. And under the slit lamp, obviously, we could see an ingrowth, but I also wanted to show the corneal OCT, and you can see the cells that are on the OCT. You see the white blobs, those are just the ingrowth cell, and the marker, the cursor, is on the area that I was suspicious. I find the OCT to be helpful in helping us see how thick and dense it is, and also we can track the growth of it. Seems to be an obvious case just because the vision's depressed, and also we can visibly see the growth of the ingrowth, the cells that are growing. It's not every day that we see on primary procedures ingrowth, but it is possible for some of the epithelial cells to get under at the interface and grow, and it's not visible. You won't be able to see them on day one. No matter how hard you look, they're tiny. The best time to visualize these things, depending on how fast they grow, is somewhere between month 1 and month 2. And I'm going to move on to the next. This is a photo of the ingrowth. And you can see there's like an area that has been, has all these tiny little cells, but the blobs of the cells that are aggregating together is basically what's causing the elevation on the cornea and disruption of the vision. So Dr. Moarefi went through removing the ingrowth, and during the, as you can see, with after the ingrowth was removed, her vision was back to being 20/20 after a month out, and there was no visible ingrowth by the following visits that we saw her. And once we noticed that vision has been, after 2 to 3 visits, stable, no ingrowth returning, then we were able to let her go. Even though there is no flap with SMILE, we still sometimes might come across some of these rare cases. And often, if the vision is not involved and the ingrowth is not really growing, then we might want to leave them alone. But as soon as the vision gets affected, then there's really not a whole lot of reason to not go through removing it. Dr. Stangs, anything you wanted to add?
No, I think that was great. I think we really rarely notice any flap complications when there is no flap, being involved in smile. So things that we really want to pay attention to is just on their follow-up, whether that's 1 month, 2 months, to make sure we take a topography. Even if it's very, very small, we want to be able to catch and monitor anything. And just like Dr. Tabanfar says, we may or may not do anything to clean it out. But in case in the future, we want to know, is it going to be visually significant? If there is anything else we can watch out for or have the patient pay attention to, those are things that we mark down.
I just want to jump in and say something as
Oh,
well.
yes.
Yeah, so it is extremely uncommon, even with LASIK, for a primary LASIK procedure, to have epithelial ingrowth. The most of the time that you'll see any type of epithelial ingrowth with LASIK is if we go back and lift the flap for an enhancement, or there's a little bit of trauma or flap complication. Those are the most likely times we will see epithelial ingrowth. In SMILE, the epithelial ingrowth seems to be more related to maybe some epithelial sheets or a small amount of epithelial cells being slid under the interface, less so commonly than epithelial ingrowth happening at the entry point. So at that second case, I want to bring attention back to when I was removing the lenticule, the area of the epithelium at the entrance of the wound was becoming soft. It's in those moments that if you ever see that soft epithelium, you really have to do a good job of making sure you irrigate and checking the slit lamp to see any cells. Sometimes it's very difficult to see it at the postoperative or the moment that you're checking them postoperatively or postoperative day one. But like Dr. Tabanfar was saying, at that like 6 to 8 week mark, they do become much more visible. And it can be anywhere. And so if we see it, like in this case, hers was central, this was likely due to epithelial sheet being uh, inside the interface that was missed. And so we do a really good job of making sure we're very thorough and making sure that if there is any epi defect at the incision point, we're making sure that we fully irrigate and that we check closely, because if there is anything that we see, we go and just remove it at that time so we don't have to deal with this later on.
Mhm. Very good. All right, so let's bring into our takeaway closing remarks about the advantages of SMILE. As we mentioned before, it is minimally invasive. It really is an easier way of going through refractive procedures for many individuals. Because of their level of activity, we're much more active doing sports, so it just removes the need for the concern for the flap and flop complications. Very quick recovery. um, it 2020 in our clinic, we generally see most of our patients are 2020 the next day after the procedure. And obviously the best part of having to go through the laser vision correction and SMILE is to be able to go back to normal life without thinking too much about the eyes. And we tend to achieve that faster with SMILE because there's less need for constant lubrication. And I find the post-operative care for SMILE to be fairly easy. We don't have to really sweat it if the patients don't come back for the 1 day post-op because we're worried about microstriae or things like that. It's DLKs are really not something we've seen with SMILE. So I think in as far as being able to incorporate it into our co-management cases, SMILE lends itself beautifully to ODs being able to take charge of the aspects of from day one from postoperative care with confidence and without a whole lot of concerns about do I need to send the patients back to the surgeon or not. So it becomes more of maintaining our patients and our independence of managing our patients. All right. Anything you'd like to add, Dr. Tseng or Dr. Moarefi? I think we're done with this, with the slides at this point. And I'm going to go through the references real quick in case if there's ever any questions of where we got our information from. All right. That was the end of our presentation. Thank you so much for taking the time and spending your evening. Please let us know if there's any questions. We would be live and be happy to jump in.
Great. Thank you guys for joining us. Hey, if you are expecting Julie Schallhorn to run this Q&A, sorry, she had to leave for a family obligation. And as you know, family always comes first. So you get me. My name is Brandon Ayres. I'm from the Cornea Service at Wills Eye Hospital. And I am currently in dark, rainy Philadelphia, but I am live with Dr. Moarefi, Tseng, and Tabanfar to answer any questions that you have. Now, guys, I've already got questions myself to ask you, and I am a cornea and anterior segment surgeon. I'm not a LASIK surgeon, but I do LASIK. So I've got several cases coming up. I do use the VisuMax laser, and I have often been tempted to switch over to Smile. I've got plenty of cases. It's a great flap maker, but it's really made for Smile. So what convinces a laser refractive surgeon primarily doing LASIK to switch over to Smile? Or maybe the better question is, what does that transition look like from LASIK to Smile as far as surgeon training and what the surgery feels like as compared to LASIK? And you know what? Let's go with Dr. Tseng first.
Well, definitely from optometry side, Smile has just been a really easy transition for our patients. As far as in the consultation and the preoperative, a lot of people, especially in our demographic, we're located in sunny California, just want less downtime. Two, dry eye is definitely a concern. So anything we can do to quicken the recovery, lessen the patient dependence on lubrication in the first kind of post-operative period is what we're looking for. So definitely, when patients hear one less invasive cut, they want to be able to not have to worry too much about accidentally rubbing their eye and returning back to their active lifestyles. We got them, and they want to be able to, wake up the next day and see the best that they possibly can. So most of our patients next day, they're very happy to be able to drive themselves to the one-day post-op, see 20/20, return to their screens, and just overall not have to be dependent on lubrication, artificial tears quite as much. So as we have started incorporating Smile more into our practice, we've noticed more and more patients opt for the Smile procedure. Not only do they understand just less complications, but overall, they want to be able to have that less downtime, better recovery, and overall just less complications, dry eye and halos afterwards as well.
So it sounds like it's some of the benefits of PRK as far as no flap, but the visual rehabilitation, or maybe even faster visual rehabilitation with LASIK. So you kind of get the cake and get to eat it too. Smile. But Dr. Moarefi,
that's a lovely way to put it.
What about the surgeon transition though? Is that a challenge? If you're used to doing LASIK, what does it look like to become a Smile surgeon?
Yeah, and that's a great question. I always say that if LASIK and PRK had a baby, it would be Smile. It's exactly how you described it. It's just that ability to have that quick recovery. But there is a little bit more technical advancements with the Smile procedure versus LASIK. Like any procedure, when you first start, there is a learning curve. It is important to kind of start slow, do maybe more higher prescription cases, so there's a thicker lenticule just to get comfortable, and then work your way down to a slightly thinner lenticule. There are some issues that can occur with Smile that we just don't see during a LASIK procedure. LASIK is very straightforward, very easy to perform for most surgeons, and we do a lot of it, and most people have a good comfort level with it. However, it really comes down to your ability to want to provide a procedure to your patients that's minimally invasive and flapless. The less corneal nerves that we can disrupt for our patients. It's the same way like when people used to get appendicitis back in the day. We used to make like a large incision in their abdomen, and now it's laparoscopic. We make 3 tiny little incisions. Smile, I look at it like a laparoscopic LASIK. And like when the old surgeons had to switch from an appendectomy to a laparoscopic appendectomy, there was a learning curve, and there are certain things that we have to watch out for. Overall, though, I think it's very simple. You just start, with cases that are easier to perform. You get the hang of it, but it becomes a lot more fun. As a surgeon, I enjoy that I get to do a little bit more, and you get much quicker at it. And then seeing how the patients, recover and have less dry eyes. And really what the patients want, as much as you have a great relationship with them, they don't really want to see you again. So the less that they have to come back to the office and visit us for post-operative visits, for dry eyes, for any flap-related complications, it's just better overall for the patient. And so we've been really happy with it in our practice. We've been really successful with how it's been going. So for us, we've really shifted more towards being Smile dominant over LASIK. However, there are some things that LASIK still has an advantage over Smile. So Smile has a smaller treatment window. So LASIK will never be replaced, but it is good to have it as an addition into your tool belt.
One last comment here. Literally a week ago, I spent about 30 minutes in the operating room lifting a LASIK flap, scraping out epithelium, and then suturing the flap down. And Dr. Tabanfar, you'd mentioned that epithelial ingrowth is pretty rare with Smile. Have you, but clearly you've had some rare cases of having to remove epithelium. Have you ever had to go further than just simply removing the epithelium? Have you ever had to suture the entry incision, or has it been as simple as just scrape out what's there, let it close primarily, and it's been treated?
Not really. So, and obviously I don't do the surgeries Dr. Moarefi does, but in our clinic, we see a lot more ingrowth issues with enhancements, especially the old LASIK enhancement, that
Sure.
when the flap is lifted, those are the point of entry is open. So the edges of the flap do get a little floppy, and cells can migrate in, and then you scrape them out and they come back. With Smile, there's generally two reasons for it. One is where the incision has been made to remove the lenticule. Sometimes we get some epicells moving in. And the second rare occasion that can happen is if there's any perforation of the cornea during the cap. So if the instrument can perforate the cornea, and then we can get some small cells in. Both of those cases, generally, it's not an open channel. That cap closes, and also when the incision heals, we don't really get a constant inflow on the microchannels that are open for the cells to feed. So we usually don't see a chronic, let's go remove, bring them back. It's as rare as they usually are one and done. So once the ingrowth, so far to my experience, after seeing Smile cases for as long as we have, it's never been a case where we ever had to worry about the regrowth of ingrowth. So I find them to be much easier to manage as far as surgical post-op and any potential for ingrowths. I think that lends itself to easier post-op care.
All right. Well, hey guys, thank you so much for the live Q&A. You've convinced me. I'm going to do Smile. No more LASIK for me. It's all Smile from here on out. And everybody else, thank you so much for joining the summit. It is now time for us to go to our closing remarks. Thanks so much for joining us.
Thank you. Thank you for joining us.
Thank you for joining us.